Learning point 10, analgesics and musculoskeletal medications. Always assess pain. Where is it? How long have you had it? What causes it? What makes it better? How bad is it? Describe it with words. Describe it with numbers. We need to measure all that as much as possible because pain is elusive. We cannot measure pain. There's no test to measure for pain. Pain is what the patient says. So we need as many descriptors as possible so that we can properly treat them. Pain is only defined by the patient, not by the nurse. Analgesics are medications that relieve pain without causing loss of consciousness. There are 3 kinds of analgesics. There's opioids, non-opioids, and adjuvants. Let's talk about each of those in turn. Now, pain is also classified by onset and duration. If it's acute, sudden onset, and usually subsides once you treat it. It comes, it goes, it's gone. Chronic pain is persistent and reoccurring. It's very difficult to treat. A lot of times the best you can do is get the pain reduced, but not gone. Pain gate is the theory for many of these medications. There's actually like a gate in the brain which allows pain signals through. Some of these pain medications lock the gate. That's how they work. There are 2 types of pain: nociceptive and neuropathic pain. Nociceptive pain is when everything is working correctly. When you smash your thumb and your thumb hurts, that's nociceptive pain. It could be somatic or visceral. Smashing your thumb is somatic, bone, joint, and skin. Appendicitis would be visceral. It's deep inside. The smashed thumb feels throbbing and hot and pain and sharp. Visceral pain tends to be deep and dull and aching and diffuse, and it's hard to figure out where it actually is. Somatic and visceral pain are normal. That's the way everything is supposed to work. Neuropathic pain is phantom pain, diabetic neuropathy, shingles, multiple sclerosis, spinal cord injury pain. This is pain that originates in the nerves. The nerves are malfunctioning, causing pain. This kind of pain feels burning and electrical. Very, very uncomfortable, horrible pain, very difficult to treat. Nociceptive pain, the smashed thumb, opioids, acetaminophen, NSAIDs, and local anesthetics work. Neuropathic pain, we're going to treat it with anticonvulsants, benzodiazepines, tricyclics, to a lesser extent SSRIs, and to an even lesser extent opioids. Now for mild pain score of 1 to 3, we're going to give probably acetaminophen or an NSAID. Ibuprofen is a good one. Those work very good for mild pain 1 to 3. Moderate pain 4 to 6, we might step up to an oral opioid, commonly a combination, such as Vicodin, which is hydrocodone and acetaminophen, or Percocet, oxycodone and acetaminophen. That's better for the moderate pain, 4 to 6. If we're looking at severe pain, 7 to 10, we're going to go straight opioid, and we're going to probably go IV. Morphine, hydromorphone, or fentanyl. Those are the high-powered, big gun painkillers. 3 classification of opioids could be an antagonist, it could be an agonist, agonist, or straight antagonist. Opioids are derived from the poppy. It's chemically related to opium. These are used to alleviate moderate to severe pain. It can also be used as a cough suppressant and the treatment of diarrhea. We'll actually use opioids to cause constipation, to slow diarrhea. These prevent stimulation of the gate. These lock the gate. You cannot use alcohol or drive heavy machinery with these medications because they can be profoundly causing CNS disturbances. We're looking at morphine as being the prototypical opioid. Everything is compared to morphine. There's codeine sulfate or Tylenol 3, hydromorphone, Dilaudid, fentanyl, meperidine, oxycodone, and hydrocodone. These are all Schedule II medications. You cannot call this order into the pharmacy. Your patient must take a paper copy of the prescription, and they'll have to have ID and they'll sign documents. It's tightly controlled. Fentanyl can be used IV. It can also be used as a transdermal patch for chronic pain, for chronic long-term pain. These patches are applied once every 3 days. When you apply them, make sure you initial them and date and time them so that they know when to take them off. An opioid antagonist agonist, these have combination activity, so it doesn't have the same highs that pure opioids have. So the street value of these drugs are less. There's lower activity or lower misuse and addiction potential with these. Opioids have a high abuse potential, high misuse potential. Opiate antagonists, this is that opiate reversal agent. Remember we talked about that when we were talking about the benzodiazepines. Benzodiazepines are reversed with flumazepine. Opiates are reversed with naloxone, or brand name Narcan. This competes with and reverses the effects of opioids. If a person has an opioid overdose, we will give them Narcan IV every 2 or 3 minutes until we get the proper response. Half-life is only 64 minutes, so we may need to redose frequently. We need to observe for respiratory depression, constipation, so push fluids, monitor for CNS disturbances, level of consciousness. If the person has respirations of less than 10 or 12, we need to try to arouse that patient, and we may need to consider that naloxone to reverse it. They can develop tolerance. That's the need for more medication for the same amount of relief. That's not an addiction. That is your body simply getting used to the medicine and requiring more. If we're getting rid of opioids, make sure we dispose of them correctly. A lot of times it'll be flushed down the toilet. Physical dependence it happens when you abruptly quit an opioid. Psychological dependence or abuse is strictly psychological, although it's just as damaging as a physical dependence. Non-opioids, these will commonly affect the inflammatory response. NSAIDs are non-steroidal anti-inflammatories. They're used for gout and bone and joint muscle pain, osteoarthritis, rheumatoid arthritis, dysmenorrhea, and fever. They work very well. They all work in slightly different ways. They are analgesics, so in other words, they block the undesirable effect of prostaglandins. They're an anti-inflammatory, and they are also an antipyretic. Take these with food. NSAIDs and aspirin take with food. They can be very tough on the stomach. Do not take these with anticoagulants, especially aspirin, because aspirin also has an anticoagulant property. Alcohol interacts with these, as do diuretics and ACE inhibitors. Watch for hypertension. Aspirin especially causes tinnitus and hearing loss, especially with long-term high doses. In children, you may want to watch for hyperventilation and CNS effects. NSAIDs, such as COX inhibitors, like ibuprofen and Motrin, and ketorolac. COX-2 inhibitors would be Celebrex. These work as pure anti-inflammatory. Ibuprofen and ketorolac are the #1 causes of GI bleeding. COX-2 inhibitors have much fewer side effects on the GI system. They do increase the risk of MI, stroke, and death, though. COX-2 inhibitors, Celebrex or celecoxib, have no effect on blood coagulation. Acetaminophen is a non-opioid analgesic. It is not an NSAID. It has no effect on inflammation. It's purely antipyretic, and it's an analgesic. It blocks peripheral pain by inhibiting prostaglandin synthesis. No anti-inflammatory effect, does not alter blood coagulation, does not cause GI bleeding. It is hepatotoxic, so we're going to watch for ALT and AST elevations. It can cause renal failure in high doses and chronic use. So we'd watch for BUN and creatinine. Acetaminophen toxicity causes hepatic necrosis, and we would use mucomist or acetylcysteine as an antidote. Gout is treated with is from a uric acid problem, either an overproduction or an under excretion. So allopurinol is indicated for too much production of uric acid. Colchicine reduces inflammation, and probenecid increases excretion of uric acid. Probenecid is only used as a preventative. Once you have a gout attack, you need allopurinol and colchicine. Allopurinol, watch for a rash. That's one of the major side effects there. All of these can cause, have side effects that will, such as elevated BUN and creatinine, uric acid levels, and CBCs. With all of these, you will push fluids, try to get 2.5 to 3 liters a day, and monitor INO. And that's it for the last of your rapid reviews.